Uh, Alejandra is there.
I haven't seen her yet, so
Yeah, I think
shall
she
I
just
just go
sent
ahead?
a message that she's having an issue with her internet. So
Okay.
she's moderating, right? Right. We might have to just
Okay, well let me go ahead and start then.
okay.
So, welcome everyone to our 13th Uveitis Grand Rounds. As the it's a service to the world of the International Uveitis Study Group, and what we're trying to do is case-based learning about ocular inflammatory diseases. And our basic structure is to have a thematic lecture on a topic, in this case, juvenile idiopathic arthritis associated uveitis, and then three cases of sort of varying abstractness, hopefully going from fairly straightforward to rather complicated, and then sort of discussion of the lessons learned from each of those cases and sort of how we can, hopefully to cover in a case-based learning approach the topic of JIA associated uveitis, and eventually we'll have a book chapter about this sort of originating from this presentation. So we're happy today to have Professor Megan Birkenstock as our thematic lecturer. Megan Birkenstock is an associate professor at the Wilmer Eye Institute and Johns Hopkins University, a uveitis expert and researcher, and part of our committee in organizing this course, if you would call it a course, as well as the education committee of the International Uveitis Study Group. And thank you very much for joining us, Megan. And why don't you go ahead and proceed with your lecture? And thanks so much for preparing it.
No, thanks. Thank you for the introduction, John. I appreciate it. I'm going to try to share my screen and also put my phone on silent so you don't have the uh, worrying about hearing about it. I'm trying to share. It says it's not responding. We'll give it a second. But thank you for the IUSG for inviting me to do this talk this morning. I'm sorry, my computer has decided to freeze.
Yeah, our photo of you is frozen too, but we can still hear you.
You can hear me? Okay. Well, that's
Yeah.
good. So that means it's still working, kind of.
Yeah.
It has the blue circle that's going around and around and around. So we'll hopefully give it a minute because I do have the PowerPoint and I just tried it in practice. So we'll see how this goes. But your
Yeah.
audio and video are perfect. There is no
What?
That's good. We're trying. We're halfway there. We're get there. Oh dear. I don't know what else to do other than see what happens. So select a window or application, not responding. Okay. Team Global, are you working on this?
I think, Megan, maybe you should log out and log back in.
Yeah. Okay. Well, I will
Is there?
be back momentarily then if I can. Let me just hit Control Delete and see what happens.
Now we see you moving.
All right, I'm
So
at
maybe
Task
that.
Manager now. So let me see if I
Yeah, it
can.
might work now because we see you now live.
Oh, okay. Let's see here. All right. I said cancel.
Right. I think she's frozen now. Rima, would you be able to send Megan a text to just log out and log back in? And
I think she's done that, isn't she? Or she's still there?
oh, there she is.
Hi. Yeah, Control Delete does work. Um, Unfortunately, it also took me out of the meeting. Can you see my screen now? I'm sorry.
Yeah, now we can see it. Good.
Awesome. All right, we should be fine from here on out, God willing. All right. Well, again, thank you for having me. I'm really excited to talk about JIA, both challenges and goals. These are my disclosures, none of which are relevant to the talk. We all know that juvenile idiopathic arthritis is the most common association with chronic inflammation in children. There's multiple presentations, with systemic onset being the least common, which is previously called Still's disease, with ocular involvement in less than 6% of children. Polyarticular has more than 4 joints affected at presentation, and 10% have ocular involvement. And the one that we see most commonly in the uveitis department is pauciarticular, with less than 4 joints involved, and account for the majority of the patients seen, mostly type 1 girls under 5 who are ANA positive on lab examination. The alternative is being type 2, which tend to be older boys, most of whom are HLA-B27 positive. Ocular manifestations usually start around 6 years old and develop within 5 to 7 years of disease onset. And the eye can be inflamed with quiescence of the joints. And so it's a disparate disease that various parts of the body can be inflamed independently at any time. Risk factors include female gender, pauciarticular onset, as we talked about, and ANA positivity. Ocular symptoms sometimes are far and few and in between, so screening is vital to diagnosis, because without it, visual sequelae, including band keratopathy, posterior synechia, and macular edema, can lead to end-stage disease of hypotony and ptysis bulbi. Screening algorithms, because of the importance of understanding that there's inflammation and treating the inflammation before complications occur, is the hallmark of prevention of complications. And so in 2019, the American College of Rheumatology changed the screening guidelines. And I really like this flow chart because it simplifies what we should do and when. And so we know our highest risk group is the oligoarthritis, which we see here on the left-hand side. And so if we're rheumatoid factor negative, and what we do is we divide into 2, ANA positive, which we know has the highest risk factors. And if they're young, they have more years to have the complications arise, in addition to having the disease for not very long. So they need the most stringent screening, and that's every 3 months. And so the alternative would be somebody who's ANA negative, so 1 less risk factor. They've had the disease for many years, because we know it'll onset of symptoms is within about 5 to 7 years on average. So the longer they have the disease, or the older they are, the less likely, if they don't have it already, to develop the complications. So we want to screen every 6 to 12 months in those cases, along with the systemic arthritis population, which we know has the lowest risk. So there have been many papers on what are best practices and ways to prevent complications in this group of children. The paper that we cite commonly in our clinic was the risk of cataract development in children with JIA treated with topical corticosteroids. So the question is, how much is too much and for how long? So topical corticosteroids should be limited to 2 or less drops per day. The risk of cataract was independently associated with the use of prednisolone acetate 1%. And so dose-dependent increases in the rate of cataract with 3 or less drops per day versus greater than 3 drops per day. And that seemed to be the dividing line. Eyes with less than 2 drops per day or 2 drops per day, the incidence of cataract was 0 per eye year. So if you're needing 3 drops or more per day, you need to start to consider immunosuppression simply for the risk of cataract. But as we all know, cataract's not the only complication. That is something that needs to be looked at in this population. And clearly intraocular pressure elevations is another source of monitoring. So eye pressure elevation in children, we found that immunosuppressive therapy and systemic corticosteroids were not associated with a higher risk of elevated intraocular pressure, even after adjusting for topical corticosteroid use. So a daily dose of prednisone, 7.5 milligrams or less, had a similar risk or less than of patients not taking oral corticosteroids. And the estimated incidence of any observed eye pressure elevation to greater than 21 millimeters of mercury or greater than 30 millimeters of mercury was either 33% or 14.8% respectively. And mind you, that the risk never goes down. Cumulative incidence of eyes with eye pressure continued to rise through the follow-up. The rate of rise tended to decline over the course of follow-up, but this is the most important part here. the cumulative incidence never returned to baseline. So once you have someone in screening, and they're always at risk. And so even with previous high pressures, you always need to monitor. Most children do require immunosuppressive therapy, as inadequate control with twice-a-day prednisolone or steroid-induced increases the development of complication with topical corticosteroids warrant use, as uncontrolled inflammation leads to the complications we've already talked about. Oral corticosteroids over an extended period of time are contraindicated because, as opposed to adults, the children can have premature closure of the epiphyses causing growth restriction, and they're not immune to hyperglycemia or osteoporosis as well. Starting with an antimetabolite and then escalation to a TNF inhibitor is the usual ratcheting up approach that one would use, because we know methotrexate is well tolerated for many years of experience as a steroid-sparing agent in rheumatology, and mycophenolate and azathioprine may be possibly less effective but have been used in the past. One of the really exciting times was when the New England Journal of Medicine and also the Lancet were publishing concurrently within about a month of each other uveitis articles. And so one of the articles I wanted to talk about today was adalimumab plus methotrexate for uveitis treatment in JIA. I'm sorry about my throat. And that was the Sycamore study. It was a multi-center, double-blind, randomized, placebo-controlled trial, hence why it was in the NEJM. Efficacy and safety of adalimumab in children 2 or older with active JIA-associated uveitis. Those on a stable dose of methotrexate were randomly assigned to a 2-to-1 ratio to receive either adalimumab or placebo. And the difference was dramatic. The treatment failure was only 27% in the adalimumab group versus 60% in the placebo group, with a hazard ratio that was clearly statistically significant. And I think what also harkens back to what we've been talking about already is that adalimumab showed corticosteroid drop sparing effect to be able to get to that 2 or less drops per day. Another trial that's worth commenting on is the Adjuvite trial, which was also a double-blind randomized placebo-controlled trial with 31 patients with ocular inflammation refractory to corticosteroids and methotrexate who received either adalimumab or placebo. After 60 days, 56% in the treatment group versus 20% in the control had decreased inflammation as measured by laser flare photometry. So again, meeting clinical endpoints with a decrease in inflammation. And then a more recent study is the Adjust study. And the question was, can immunosuppression be discontinued in patients with JIA-associated uveitis? We know we need to start it, but can we stop it? A multi-center, double-masked, randomized placebo-controlled trial, patients aged at least 2 years who had controlled arthritis and uveitis for at least 1 year on adalimumab, and they were given either adalimumab or placebo every other week until the 48-week visit or treatment failure. Primary outcome was the time to treatment failure, and that it was either recurrence of uveitis or arthritis. And you can see here in the Kaplan-Meier curves that the time to failure was clearly higher in the or was shorter in the placebo group, as you can see here. So discontinuing adalimumab led to higher rates of recurrence of uveitis, arthritis, or both in patients who previously had controlled disease. All patients with a treatment failure successfully regained control of inflammation by the end of the 48-week time mark. So again, it seems that adalimumab is effective in controlling ocular inflammation in patients with JIA, but it needs to be continued. So when do you use a TNF inhibitor as opposed to an antimetabolite as your first-line therapy? So you really want to be more aggressive in a child who's presenting with sight-threatening complications, including macular edema, cataract, and glaucoma. And starting methotrexate and a TNF inhibitor is recommended over methotrexate monotherapy in this group. Another benefit of starting both is a decreased risk of antibody formation to the TNF inhibitor. So adalimumab is not the only TNF inhibitor in our armamentarium, and so a brief word on infliximab and golimumab. So for infliximab, a prospective multicenter study on JIA refractory to standard immunosuppressive therapy who were corticosteroid dependent demonstrated a higher remission rate. Um, uh, and adalimumab was favored over rituximab due to the ease of administration. But the beauty on the converse is if you do develop adalimumab antibodies, or you need to increase the dose or change the timing of the infusions, that is the benefit of infliximab over adalimumab. Golimumab is limited to one retrospective single center study, and of the 8 responders, 5 had continued quiescence. However, further evidence is needed. Etanercept, there was a randomized placebo-controlled double-masked clinical trial with JIA-associated uveitis patients, but it did not provide significant efficacy above placebo. And so etanercept, because of its chemical composition as a trap molecule, so trapping the TNF protein instead of being similar to it, is great for joint inflammation, but may induce uveitis in both previously uninvolved eyes. So when TNF are inhibitors are contraindicated or fail, patients with active uveitis can consider the use of tocilizumab. And so tocilizumab is a humanized monoclonal antibody to the interleukin 6 receptor, preventing IL-6 from binding to its soluble and membrane-bound receptors. And it's available in subcutaneous administration, which is easier for at-home administration or intravenous. A retrospective study of 17 patients with treatment-resistant active uveitis resulted in inactivity in 10 patients with a mean of 5.7 months. There was also a multi-center study with 25 patients with 47 eyes with severe uveitis and macular edema that showed after 6 months of treatment, nearly 80% of patients demonstrated less anterior chamber inflammation, with 88% showing improvement after 1 year, including steroid-sparing success and macular edema reduction. So we've talked about some of the medications to avoid complications. We've talked about when to use them if there are complications. Now let's talk just briefly about how to handle them. So cataracts. I always make the analogy that you never want to run into a burning building. And it's the same thing when you're taking out a cataract in an eye with a history of uveitis. There's nothing more inflammatory to incite rebound inflammation than doing surgery on an eye that still is actively inflamed. And so we like to wait for cataracts to be removed after 3 months of quiescence. So no macular edema, no anterior chamber reaction. And depending on the age of the patient, a concurrent pars plana vitrectomy and posterior capsulotomy may need to be performed, especially if the patient is unable to sit at the YAG laser and be able to have a YAG capsulotomy in the future. And so we want to maximize immunosuppressive therapy and increase topical steroids preoperatively, and then follow up frequently with aggressive treatment of the inflammation. And again, I always tell my families, you need to continue the immunosuppression afterwards. The goal is not to just get the cataract out and stop all of your medications. This is a long-term process, and we need to be very thoughtful about increases of the medications, as we just talked about, preoperatively, but then continue them postoperatively with a slow topical taper. And as far as lens implantations go, we know that children mount a strong inflammatory response, hence why they might need a capsulotomy sooner than an adult. And pupillary membranes can form rapidly and cocoon the lens. So the decision to implant a lens should be on a case-to-case basis. And in a patient who's been quiet with controlled disease, it normally is not a problem. But in the patients who are an amblyopic risk, can the patient wear a contact lens if they're left aphakic because of band keratopathy? Would the parents be able to put a contact lens in, or are you better off leaving the lens in? And will the patient be able to adhere to the pre-op and post-op instructions? Because if they can't, again, you can have membranes and cocooning of the lens with more complications postoperatively. The placement of the lens is also a topic for discussion. because you can limit synechial formation if you place the lens between the anterior capsule and the iris. And that's the discussion of sulcus versus in the bag placement. But there are also case reports over time as these children are moving into adulthood that the lens can drop over time. So it may not so much be placement, but just making sure that we reduce complications, reduce the risk of zonular laxity due to uncontrolled disease, and limit the amount of surgery that's needed. So posterior synechia and white cataract formation, in order to give the best placement of the lens possible in the clinical scenario. So just a few take-home points. JIA-associated uveitis is a chronic condition, and as we found, the medications need to be a continued topic of discussion and area for patient compliance. Local corticosteroids have a dose and route of administration dependent increase in intraocular pressure. The highest risk of intraocular pressure rises, and we also saw this in the site studies, occurred with intraocular injections or periocular injections of corticosteroids, with the least pressure rise of corticosteroid use being in oral formulations. And so you have to be careful if you're considering intraocular injections in a child with cystoid macular edema because of this. Frequently, early initiation of immunosuppression for control of inflammation and prevention of complications is paramount for the best visual prognosis. Prospective and larger studies are needed to assess the efficacy of the TNF inhibitors other than adalimumab and also third-line agents beyond tocilizumab. And with that, I thank you, and thank you again to the organizers for allowing me to present.
Fantastic. Thank you very much. Ram, I don't know if you have any further comments about your trial since we're fortunate enough to have you here.
Yeah, no, thank you very much. I think the adalimumab trial, Megan's addressed much better than even I could. We can touch on perhaps at the end after Panosh's talk on the fact that there is a randomized trial of tocilizumab as well. And now we have presented data on baricitinib, which obviously is an important feature. And there are ongoing trials. The key is to say that the advent of adalimumab, as you all know, has revolutionized the care of both pediatric and adult uveitis. But there is a need in about 30 to 50% of the patients. There's a proportion of patients who have primary lack of response to adalimumab, and a further 20 to 30% of the patients who have secondary lack of response to adalimumab. For those patients, we need other agents really, and that's probably one of the discussion points of whether that should be an IL-6, that should be a JAK inhibitor, filgotinib with its preliminary results, and so on. So,
yeah, it's great having so many more options than at the beginning of my career. Alejandra, do you want to pick up now?
Yeah, thank you. So great talk, Megan. Now we will have Claudia Fabiani's fellow and continue with the case presentations. Thank you. And I think it's Alessandra Pagliara from Italy.
Ayara, who trained in Siena and now works at Gaslini's Hospital's Pediatric Uveitis Clinic, showing a particular interest in this field. So the ground is yours, Alessandra. Go ahead. We cannot hear you, Alessandra. Switch on the microphone.
Yeah, we see you and we see your slides. Sometimes on mine, if I increase the volume, it will start working.
Can you hear me
So
now?
Ram offered to.
Now we can hear you. Yeah. Yeah.
Fantastic.
Okay. Perfect. So.
Okay, put it full screen, please.
Yes. Okay, can you see my slide?
Yes, go ahead.
Yes.
Yes. Now it's okay. Thank you.
Okay. Hello, everyone. Thank you for your kind invitation. Today, I'm going to talk about two classic cases of JIA-associated uveitis. So let's start with the first case. She's a female patient diagnosed with oligoarticular JIA at the age of 2.5. She presented a positive family history with rheumatoid arthritis and psoriasis. And she initially presented with joint symptoms at proximal interphalangeal, knee, and elbow. She tested positive for ANA, and she was treated with prednisone tablets, but she discontinued due to difficulty in administration. So after 2 months, there was a persistence of joint symptoms, and rheumatoids started with steroid joint infiltration and methotrexate subcutaneously. After 1 month, due to persistence of joint symptoms, they added Flazacort. She did the first ophthalmological evaluation at diagnosis that resulted negative. After 4 months from diagnosis, she presented to our center, and arthritis was under control. Ophthalmological evaluation was negative, but after 1 month, due to new joint symptoms, rheumatologists increased the methotrexate dose, introduced ibuprofen, and performed steroid joint infiltration. After 1 month, still joint disease activity, and so they added etanercept. At this point, ophthalmological evaluation was still negative. After 2 months, she discontinued methotrexate due to adverse events, and after 2 months, she had no joint symptoms. She was only with etanercept for systemic therapy, and for the first time, she resulted positive at the ophthalmological screening. And so she had onset of bilateral uveitis. Here we have our timeline. On the top, we can see the main events, and at the bottom, we can see ophthalmological screening evaluations. So she did ophthalmological evaluation at the baseline, then after 4 months, after 2 months, and then after 4 months, where we have the onset of uveitis. Here we have ocular examination. So the best corrected visual acuity was 2032, and she presented with few dusty keratic precipitates, regular pupil without posterior synechia, and 2+ cells and flare. Fundoscopy examination and macular CT were normal. So for systemic therapy, we switched from etanercept to adalimumab, 20 milligrams every 14 days. And for topical therapy, we introduced a psychoplegic tropicamide, 3 drops daily for 2 weeks, then 2 drops daily for 1 month, and 1 drop daily. For topical steroid, we introduced dexamethasone, 4 drops daily for 1 week, and at follow-up visit after 1 week, she had inflammation activity, but it was decreased. So we tapered 3 drops daily for another week, 2 drops daily for 1 week, and at follow-up visit, she had no inflammatory activity. So we tapered again dexamethasone to 1 drop daily for other 2 weeks, and at follow-up visit, there was no anterior segment inflammation. So we controlled the patient after 1 month, and we see that there was a mild reactivation, and so we introduced again topical steroids and cycloplegics. And inflammation resolved in 3 weeks. So let's go back to our timeline. After these 2 episodes of uveitis, the patient has no experienced any further reactivation. She is no longer on topical therapy and is receiving systemic treatment with adalimumab, always 20 milligrams every 2 weeks. We are now at 5 months of follow-up, during which she underwent follow-up evaluations every month for the first 2 months, and then every 2 months. This is the ocular examination after the 2 episodes of uveitis. So her best visual acuity is 20/25, and the anterior segment fundoscopy examination and the macular CT were normal. So in conclusion, JIA-associated uveitis typically presents as silent chronic anterior uveitis and may only lead to symptoms when ocular complications are present or the vision is compromised. So ophthalmological screening is essential to prevent complications such as benkeratopathy, posterior synechia, cataract, glaucoma, and macular edema. And many studies said that there are many important risk factors as female sex, anapositivity, and uveitis usually occur with the first year from diagnosis. And children diagnosed with JIA under the age of 6 or 7 are more likely to develop uveitis, and this justifies a narrow screening interval. Now let's move to the second clinical case. The second case involves a 13-year-old male with a positive family history for ankylosing spondylitis. And he tested positive. He has a history of enthesitis-related arthritis, diagnosed at 6 years old, and he tested positive for HLA-B27. And he was under treatment with methotrexate and etanercept, introduced after previous treatment with adalimumab, withdrawn due to loss of efficacy. He presented with acute anterior uveitis, experiencing blurred vision, redness, and pain in the left eye over the past 5 days. And his last eye exam was 10 months ago, and everything was within normal limits. This is the ocular examination. So his right eye was normal, but the left eye showed significant inflammation. His best visual acuity was 20/50. And anterior segment showed perikeratic injection, non-granulomatous keratic precipitates, 4+ cells and flare, and fibrin in the anterior chamber. He had posterior synecdoche. The funduscopy examination was within normal limits, but it was a very difficult examination due to media opacity. Here we have some images of the day one of this patient. So we have a photo of the anterior segment that shows perikeratic injection, fibrin in the anterior chamber, and macular CT was normal. And then we have an anterior segment OCT that shows posterior synecdoche and fibrin in the anterior chamber. So for systemic therapy, we switched from etanercept to golimumab. He continued with methotrexate, and we added prednisone tablets with a tapering in 2 months. For topical therapy, we started with dexamethasone hourly dosing for the first 3 days while the patient was awake, and then we reduced to 6 times daily for 7 days, then 5 times daily for 7 days, and so on, proceeding to 4, 3, 2, and finally 1 every 7 days. We added also phenylephrine and tropicamide twice daily to maintain pupillary dilatation and to try breaking posterior synecdoche. So here we have images of the patient's eye on day 2. There is still redness, perikeratic injection, and we can see again fibrin in the anterior chamber and posterior synecdoche. Here we have the images of day 3 and day 4. So we can see that the treatment is effective, and in the left image we can see an irregular pupil due to synechia. And on the right image, we can see further reduction in fibrin and clear anterior chamber. This is the ocular examination at 5 weeks from the event, and so his best corrected visual acuity was 20/20. Anterior segment shows no activity inflammation, and we continued with tapering topical and systemic therapy. The patient was monitored every month for the first 3 months, and then every 2 months. And after 1 year or follow-up, he had no recurrence. And he continues with his systemic therapy, golimumab and methotrexate, and local therapy with tropicamide, 1 drop in the evening before bedtime, obviously in left. Thank you for your attention.
Thank you, Alessandra. Nice presentation, nice cases. And now we'll have Dr. Claudia Fabiani discussing the cases you presented.
Okay, I'm going to share my screen. It's a little bit slow. Okay. Can you see my slides?
Yes.
Okay. So thank you very much, Alejandra, for organizing this wonderful initiative. Okay, now let's dive into today's topic. Children account for 6% of uveitis cases, with JIA being the leading cause, responsible for up to 50%, and onset peaks between 6 months and 4 years. JIA is arthritis lasting at least 6 weeks in children under 16 years of age. And as we heard from Megan, there are 7 subtypes. Uveitis occurs in about 20% of oligoarticular JIA cases and about 5% of polyarticular cases, with more than 90% developing it within 4 years, highlighting the need for close ocular screening. Juvenile enthesitis or spondyloarthritis occurs in children under 16, with ankylosing spondylitis typically starting after 10. African American children are more often diagnosed with enthesitis. Uveitis related to enthesitis can resemble adult spondyloarthritis-related acute anterior uveitis. Although making an extreme simplification, we can say that more frequently in children with JIA, the classic phenotypes of uveitis are chronic anterior uveitis and acute or acute recurrent anterior uveitis. Chronic anterior uveitis, often linked to oligoarthritis in young NA-positive females, is characterized by lack of symptoms. The eye is typically white. The activity of this usually bilateral non-granulomatous chronic and insidious uveitis is detected by counting anterior chamber cells. Due to its subtle nature, it often goes undetected until complications arise, leading to a delayed diagnosis and treatment. Ocular screening is crucial for at-risk patients to prevent asymptomatic vision loss. Guidelines still evolving focus on risk factors like oligoarthritis, female gender, anapositivity, arthritis onset, and JIA duration. Uveitis related to psoriatic arthritis, polyarticular seronegative arthritis, and enthesitis can present asymptomatically, and in these cases, screening should be still performed. It is also important to perform screening in those with idiopathic chronic anterior uveitis. JIA-associated uveitis is diagnosed via slit lamp examination, grading anterior chamber inflammation using the SUN scale. Laser flare photometry quantifies flare, but is not widely used, while anterior segment OCT is promising for detecting cells and acceptable for children. However, the key remains the evaluation by an ophthalmologist specialized in uveitis. OCT maps and ultra-wide field imaging techniques like wide field fundus fluorescein angiography have shown that also subclinical posterior segment inflammation may be present. Moving on to pediatric uveitis related to juvenile enthesitis, it is more common in HLA-B27 positive adolescent males. However, like in adults, HLA-B27 positivity is not necessary for diagnosis, as some of ankylosing spondylitis patients are B27 negative. Indeed, HLA-B27 prevalence varies across ethnic groups, with about 10% of Caucasians testing positive. HLA-B27 is a risk gene for anterior uveitis, even without ankylosing spondylitis. In fact, there is a specific form of uveitis known as HLA-B27-associated uveitis unrelated to systemic disease. The majority of ankylosing spondylitis-associated uveitis or enthesitis-related uveitis cases present as acute non-granulomatous anterior uveitis, which may be monophasic or recurrent, unilateral, alternating unilateral, or more rarely bilateral. The inflammatory episode is often highly symptomatic, with photophobia, pain, and blurred vision, typically preceded by characteristic prodromal symptoms within 3 days of onset. During an attack, ophthalmological examination shows intense perikeratotic reaction, significant anterior chamber inflammation with many cells, and the fibrin network in the pupillary area, sometimes with hypopyon. Synechiae formation and low intraocular pressure are also common. The posterior segment is usually unaffected, but in severe untreated or recurrent or chronic cases, optic disc inflammation and macular edema may develop. OCT is valuable for detecting both cystoid and non-cystoid macular edema, early epiretinal membranes, mapping posterior pole thickness, and tracking optic disc edema and intraretinal fluid regression during follow-up. Other complications include posterior synechiae, iris Bombeck, glaucoma, hypotony, and cataract formation due to chronic inflammation, synechiae, and steroid use. The main treatment for pediatric uveitis is primarily chronic and systemic steroid-sparing therapy. Immunosuppressive systemic treatment is essential for chronic anterior uveitis, whether idiopathic or related to JIA, as well as for non-anterior uveitis. For acute anterior uveitis cases, systemic treatment is based on factors such as the presence or absence of enthesitis, relapse frequency, attack severity, and corticosteroid dependency, either topical or systemic. The use of topical, regional, and systemic steroid remains valuable for controlling ocular inflammation at the correct dosage, with careful attention to limit their use over time to reduce potential side effects in pediatric patients. Regarding topical treatment, initial dosage and choice of drug potency depend on the severity of uveitis. Cyclopentolate eye drops are commonly used to prevent posterior synechiae and reduce pain for ciliary muscle spasm in children with active uveitis. Unilateral cycloplegia is avoided in young children to prevent amblyopia. Mydriatics like phenylephrine are used to break synechiae. Methotrexate is the first-line steroid-sparing systemic treatment for managing JIA-associated uveitis. Adalimumab and monoclonal TNF inhibitors such as infliximab and golimumab are increasingly used, as already said, in combination therapy, as well as increasingly in monotherapy, radically improving the visual prognosis in these young patients. A multidisciplinary approach is required for the management of JIA-associated uveitis. I take the occasion to thank the multidisciplinary pediatric uveitis team in Siena. Our center in Siena is part of the European Reference Network for JIA, is an accredited center by the Italian Society of Pediatric Rheumatology, and of course is an AIDA center, and I thank you for your attention.
Thank you so much, Claudia. Nice presentation. And how often do you see, or how much do you see of familial autoimmunity? So the patients that Alessandra presented had this family history.
Yeah, that was really impressive. We don't usually see so many components of the family affected by ankylosing spondylitis and B27 positive, but genetic in children is more prominent for sure.
Because we see familial autoimmunity in a important percentage of the patients. So I don't know if Ramanan or
yeah, there is. Thank you for that. There's very good data to show that if you have one autoimmune disease in the childhood, such as juvenile idiopathic arthritis, you have a very high risk of having a second one, which might usually be celiac, vitiligo, Graves, hypothyroidism, inflammatory bowel disease, either in the siblings or in another family member. So this is well recognized. Compared to control population, the affected individual will have a higher risk of having a second autoimmune disease and will have a higher prevalence of autoimmune diseases in other family members. So,
no,
yeah,
I totally agree with that. But these kind of patients had many family components with ankylosing spondylitis and B27 positivity.
Yeah, and Ramanan, you have touched a very, very interesting topic, because I was asking for familial autoimmunity, but we are seeing also what you talk about, not only familial, but polyautoimmunity or multiple autoimmune syndrome in these children. So it would be great to make a study, because we are seeing a lot of children with, for example, autoimmune thyroid disease, or any other kind of. We have a one with diabetes mellitus type 1.
Type 1, yeah.
Interesting. So thank you so much. Now we will move to Dr. Radgondia Mer. We'll discuss the second case from Israel, presented by her fellow Sarah Abdel Jalil. So, Sarah, the floor is yours.
Hello, everyone. Hello, everyone. This is a pre-recorded video. My name is Dr. Sarah Abdel Jalil, a uveitis fellow in Hadassah Medical Center. I would like first thank the IUSG board and Professor Amer for this opportunity. I will start my presentation with the case of a 5.5-year-old girl that her mother noticed right eye redness and she was not focusing properly with that eye. She also referred recurrent episodes of redness in the past that was treated by a family doctor with topical antibiotic ointment. Her examination in the ER showed visual acuity of the right eye finger counting in the left eye was 0.3. Her intraocular pressure was 24 millimeter mercury and the left eye was 16. As you can see in the external photo of the right eye, there was signs of band keratopathy, posterior synechia, iris atrophy, and cataract. Also, examination showed right eye RAPD. Anterior segment examination showed bilateral medium-sized wide cavities with AC reaction plus 1 cells, flare plus 3. And because of the cataract, there was no fundus view in the right eye, and the left eye was within normal. So our patient underwent B-scan ultrasound, which showed flat retina and thickening of the macular area, which was suggestive of macular edema. Our differential diagnosis for this patient included juvenile idiopathic arthritis, tubulointerstitial nephritis and uveitis syndrome, and sarcoidosis. Upon asking for review of system, she had no arthralgia, no skin rash, no fever, no abdominal pain or diarrhea, nor any respiratory symptoms. Her family history included a mother that was diagnosed with rheumatoid arthritis at the age of 22 and was treated with etanercept for 2 years, and since then she is in remission. Her brother also was diagnosed with celiac disease, but our patient was tested before for celiac disease and was negative. She was assessed by a pediatric rheumatologist, and examination showed no signs of systemic disease. She was also examined by glaucoma clinic, and examination showed open angle, no signs of neovascularization or anterior synechia. Her blood work showed ANA positive, rheumatoid factor negative, PBD negative, and serology for hepatitis also was negative. She was started on topical treatment, Predfort, and anti-glaucoma drops for the right eye. In addition to systemic treatment, high-dose oral steroids. 2 weeks later, methotrexate was also added. 3 weeks later, she presented again to the ER with a complaint of right ocular and periorbital pain, few hours prior to presentation, while she was still on treatment. Her visual acuity was the same. Her intraocular pressure in the right eye was 40 millimeter mercury, with mild inflammation in the anterior chamber in both eyes. She was managed in the ER with topical anti-glaucoma drops in the right eye, and her intraocular pressure dropped to 17 millimeter mercury. So our discharge plan was to continue on methotrexate, tapering of oral steroid dose, and adding anti-glaucoma drops for the right eye. 1 week later, she was examined in the uveitis clinic. Her visual acuity dropped in the right eye to light perception. In the left eye was 0.6. Her intraocular pressure was 46 millimeter mercury. In the left eye was normal, with mild inflammation in both eyes. She underwent anterior segment OCT. In the left eye was normal. In the right eye, there was signs of shallowing in the anterior chamber depth, and the dense cataract pushed the iris forward, closing the angle. So our patient, because of the dense cataract and the high IOP, she underwent urgent surgery the next day, enthectomy, anterior vitrectomy, and she was left aphakic in the right eye. 2 weeks post-op follow-up, her visual acuity in the right eye was hand motion, in the left eye 0.6. Her intraocular pressure was normal, with minimal inflammation in the anterior chamber. Her fundus examination showed right eye optic disc pallor, in the left eye was normal. Also, in the OCT retinal nerve fiber layer, there was marked thinning in the right eye. In the left eye, it was within normal limits. So she had a good outcome post-surgery without significant inflammation, but her OCT showed right eye cystoid macular edema. So our plan was to start adalimumab injections every 2 weeks, in addition to topical nebafenac, and continuing steroid and methotrexate. 2.5 years later, her best-corrected visual acuity reached in the right eye 0.3 with contact lens, left eye 1. She had a quiet anterior chamber in both eyes, right eye aphakia, controlled intraocular pressure with no signs of macular edema. She is still on adalimumab injections every 2 weeks, methotrexate injection weekly, and topical anti-glaucoma drops for the right eye. Now to continue our discussion with Professor Radgund-Amer. Thank you so much.
Thank you, Sarah. Great case. And now, Radgonde, please discuss the case.
So, hello, everybody.
Hi,
and I would like to thank Sarah for beautifully presenting the case. And I would like to thank the leadership of the IUSG for organizing these insightful webinars. So as you have seen from the case presented by Sarah, that this girl presented with a multitude of ocular complications. And I would like in my talk to focus on two of them, cataract and macular edema. And in the last part of my talk, I would like to elaborate on the similarities and the differences of idiopathic chronic anterior uveitis versus JIA uveitis. So as we have seen from publications around the globe, ocular complications do occur in a significant percentage of patients at the initial visit. You see on the left study from Germany, in 45% of the patients, uveitic complications were noted at the initial visit. In one study from the United States, 67%. In one study from Italy, 30% had at least one ocular complication. And in all these studies, the three most commonly encountered ocular complications, they are posterior syneria, cataract, and band keratopathy. The risk factors for presenting with any ocular complication, they include the duration of the uveitis, the shorter duration between the diagnosis of uveitis and arthritis, ANA positivity, and the presence of AC flare of +1 or more at presentation. And actually, these same risk factors, they are risk factors for having poor vision at presentation, for having a visual acuity of 20/50 or less. The predictors of complications at the final visit, they include having complications at the first visit with an odds ratio of 80 and having uveitis before the diagnosis of arthritis with an odds ratio of around 21. And we know that specifically in this group of patients, uveitis is detected late since they don't have arthritis and they are not referred to be periodically checked by the ophthalmologist. So regarding cataract, it is the most common complication that causes reversible visual loss. It is encountered in about a third of the patients, and we know that in children, it may lead to amblyopia. In this study that elaborated and discussed the 18-year outcome in the population-based Nordic cohort study, all the eyes that had uveitis before JIA developed cataract. This is an older study from the Netherlands before the era of biologic therapy. from 2007, and this study showed that the presence of posterior synephia at the time of diagnosis of uveitis, it resulted in a significantly shorter interval to cataract extraction than when no posterior synephia were present. So the difference was 3 years versus 8.5 years when they didn't have posterior synephia. When methotrexate was started during the first year after the diagnosis of uveitis, the development of cataract was not accelerated, but was rather postponed by 3.5 years. Another important observation of this study was that children in whom uveitis was the initial manifestation, they had significantly shorter interval to cataract extraction. So the difference was 3.5 years versus 6.6 years. And therefore, the authors concluded that the presence of posterior synephia may be an indication for early treatment with methotrexate because this drug was associated with a delay proceeding to cataract extraction. So now, since we are in the era of newer medications and we have the concept of adequate immunosuppression that is aimed at zero tolerance of inflammation, the outcomes of cataract surgery improved. And we know that it is recommended that the AC be free of inflammatory cells for a period of 3 months before cataract surgery, and these eyes need to be treated with perioperative steroids. The surgical treatment of cataract remains challenging, and the major point of controversy is whether to implant an IOL. We know that the IOLs, they might aggravate the inflammation, and they may act as a scaffold for the development of membranes over the IOL, leading to cocooning of the IOLs, as you can see in this figure, pupil distortion, and more importantly, cyclitic membrane formation, which may lead to chronic hypotony and phthisis bulbi. So cataract surgery with IOL implantation may be considered in well-selected children. However, we know that others choose to perform combined lensectomy, vitrectomy with no IOL implantation. This study from 2010, before the use of the biologic therapies, showed us the long-term ocular complications in pseudophakic versus aphakic eyes. And there were no significant differences between these two groups of eyes with regard to complications like secondary glaucoma, CME, and optic disc swelling. In this study from Italy that compared lensectomy with primary versus secondary IOL implantation, and secondary was performed after an average period of 1 year, so the visual acuity at 24-month visit was better for the eyes that received secondary intraocular lens, and the complications were much higher in the eyes with the primary IOL implantation. So as you can see the numbers, secondary open angle glaucoma developed in 61% and retrolental membrane formation in 71% of the eyes that had primary intraocular lens implantation. And just also to highlight another point here is that even in the eyes that received secondary intraocular lens implantation and they were optimally controlled with regard to the inflammation before the surgery, still these complications occurred in a significant percentage of eyes, 21% for secondary glaucoma and for retrolental membrane formation. This is a more recent study from 2021, and this study wanted to show us the outcomes in the era of biologic therapy. So the patients in this study were stratified into two groups: the biologic group that received the antimetabolites and perioperative steroids, and the biologic group that received biologic therapy and the antimetabolites. So you see the age at diagnosis was pretty similar between the two groups, around 5 years, whereas the age of surgery was older for the biologic group. They were around 11 years versus 8 years for the non-biologic group. So probably they were better controlled with regard to the inflammation. And this graph shows us the distance-corrected visual acuity. And in the biologic group that is shown here in the black line shows us improvement post-operatively at all time points: 1 month, 12 months, and 48 months. Whereas in the non-biologic group, the visual acuity did improve only at 1 month post-operatively. Here we see the post-operative complications between the two groups, and as you can note, there was no statistically significant difference between the two groups. And actually, the two groups did develop serious complications in significant percentages of eyes. Look at the synechiae, cyclitic membrane, IOL explantation, macular edema, filtering surgery, and retinal detachment. So the authors concluded that IMT with biologic drugs can improve the visual outcome after cataract surgery, but it does not significantly reduce post-operative ocular complications. Now to the second complication that our patient presented with. She had macular edema, and as you can note also, she has fine epiretinal membrane. And macular edema is an infrequent complication that is observed in around 3% of the eyes at the initial visit. In this cross-sectional study, the OCT showed maculopathy in 84% of the eyes, mostly in the form of perifoveolar thickening. Half of the eyes had macular edema, 18% had foveal detachment, and 10% had atrophic irreversible changes. The study from the Netherlands showed in their group of patients that macular edema is a late complication. It developed in a quarter of their patients after a mean interval of around 12 years. And in this study, uveitis as the first manifestation was an independent risk factor for development of macular edema with a hazard ratio of around 4. This was confirmed in another study from Germany, where in their study, 18% had macular edema, 4% at baseline. However, 14% developed macular edema as a late complication after a mean period of around 5 years. And these patients who had macular edema, they were older, they had longer duration of uveitis, and they had worse best-corrected visual acuity. And very similar to our patients, they had additional ocular complications, band keratopathy, posterior synechiae, epiretinal membrane, optic disc swelling, and cataract. And it was noted in this study that the eyes had a progressive increase in the flare meter measurements 6 months in the period of 6 months before the onset of macular edema, indicating worsening inflammation before the diagnosis of macular edema. And this was reflected also by having a drop in the IOP, by having worsening in the best-corrected visual acuity, and by having an increase in the occurrence of optic disc swelling, where at the time of macular edema onset, it was observed in about half of the eyes. But still, the future is promising, and we have more and more publications telling us about improved clinical outcomes in patients in the last decade. This study from the Netherlands stratified the patients into cohort 1, who were diagnosed to have uveitis before 2010, therefore before the era of biologic therapy, and cohort 2, who were diagnosed to have uveitis at or after 2010. And as you can note, there is a marked decrease in cataract surgery, there is a decrease in secondary glaucoma, decrease in legal blindness, and visual impairment. And this is, of course, because of earlier access to tertiary care centers and earlier introduction of immunomodulatory therapy. So what are the similarities and the differences between patients who have idiopathic chronic anterior uveitis and patients who have JIA uveitis? So this study extracted data from the prospective nationwide pediatric rheumatologic database. And in this study, patients were stratified into 3 groups. Group 1 were the patients who only had uveitis without arthritis. Group 2 had arthritis first, and Group 3 had uveitis first. So with regard to the phenotype of uveitis, it was pretty much similar between the 3 groups. So they had predominantly anterior uveitis, it was of an insidious onset, and it was mostly bilateral uveitis. However, the visual acuity was worse in the eyes that presented with uveitis only or with uveitis first, and of course it was better for the patients who presented first with arthritis, since we know that these patients, they are usually referred for periodic examination at the tertiary care ophthalmology clinics. With regard to the complication rate, it was much higher in the patients who had uveitis only or uveitis first. And you see all the different complications were higher: glaucoma, syneria, cataract, trace opacities, and retinal detachment. However, with regard to the treatment, there was no statistically significant difference, and patients were treated in pretty similar manner. With regard to the use of the DMARDs, the use of methotrexate, adalimumab, systemic and topical corticosteroids. And also, uveitis inactivity was achieved at similar frequency in these patients. And this led experts to consider these conditions as analogous diseases that need to be treated in exactly the same way. And this has also been confirmed in the most recent recommendations of the SHARE initiative, where treating patients with chronic anterior uveitis was included in the recommendations for treating patients with JIA uveitis. So the take-home messages are that even in the era of biologic DMARDs, JIA uveitis still bears the risk of irreversible visual impairment. Early diagnosis is essential in order to initiate appropriate therapy and to potentially reduce the morbidity of the disease. And more importantly, universal screening of vision in childhood is essential. And I would like to thank you very much for your attention.
Thank you so much, Ratcon, the fantastic talk. So now we will move, and after that we will have I would love to have discussion about the surgery, the cataract surgery in patients with JIA. But after the presentations finalized, thank you so much, fantastic. So now we will move with Dr. Ramanan and his fellows, Panayoti Matsoglu from the UK. They will present and discuss the last case, and finally we will have a discussion.
Over to you,
Dr. Ramanan. Yeah, Dr. Matsoglu.
Yes, thank you. Excellent pronunciation, might I add. I go about to share my case.
Okay.
Can you see it full screen?
Yeah, we can see it, but it's not in a presentation mode. No?
Very good.
Now it's perfect. Thank you.
Excellent. So thank you so much for inviting us to talk at IUSG. I'm a clinical lecturer in ophthalmology based in Bristol. And the case that I've picked to present is of what is now a young man. He's now 19, but was 2 when he first presented. And he was picked because he was actually there for every single major trial that we run at our center. So you'll see as he progresses through childhood to adolescence to adulthood, how he's trialed almost everything under the sun. These are my disclosures, none of which are relevant. So Max, as we will call him for the talk, presented in March 2007 in A&E, followed by rheumatology, with essentially stiff and aching joints, particularly in the ankles, very much in the mornings, causing him to limp. He had swollen red joints with restricted movement. He was diagnosed with JIA oligoarthritis when he was 2, and initially managed with NSAIDs. By October, poor response to those, and he was admitted for intra-articular steroid injections ×5 and started on systemic corticosteroids with addition of oral methotrexate. And then ongoing uveitis screening was commenced, which we've talked about already in Megan's talk, but it essentially, prevalence of it is high. Studies say 8 to 30% across, but can be as high as 35 to 57% in the oligoarticular young onset group. In the UK, the screening that we do is slightly more frequent than the ACR guidance. So I appreciate there's regional variation across the world about how frequently uveitis screening is done. We start screening within 6 weeks of referral, then 2 monthly for 6 months, and then do 3 to 4 monthly screening until a period of age which is determined by the subtype of JIA that the patient has. So we don't go up to 6 to 12 months. So he started uveitis screening, but at some point he did not attend his appointments, for a total appointments of 8 months lost in screening. And that's an interesting side note, because him missing all those appointments led to a causal analysis to understand why did he not attend, which led to a new pathway for ensuring attendance for all future patients at Bristol Eye Hospital. So when he presented 8 months later, he had severe left-sided AC inflammation, +3, +4, with 360 posterior synechiae, macular edema, band keratopathy, and, as you would expect, associated visual reduction. These are the scans to the left. The top one, the top OCT, is the one at presentation. I apologize for the poor quality, but this is from 2008. These are radial scans on an old OCT machine, so that's what we get. So he was started on systemic corticosteroids, orbital floor, triamcinolone, I believe it was, topical drops, and commenced on the adalimumab, which was at that point being used as for recruitment for the Sycamore trial. And this was alongside 10 milligrams of methotrexate. The scan below is Max 2 months later, with resolution of the edema and reduction of the inflammation. I know we've talked about this already, and Prof. Ram will talk about it in a bit, but essentially the Sycamore trial, which was recruiting at the time in Bristol, showed efficacy for adalimumab in patients with methotrexate-resistant JIA uveitis. Now, a little timeline about Max going from 2008 to 2012. So, as I said, the edema resolved. He then developed an epiretinal membrane, and to avoid the ensuing amblyopia, which was likely secondary to the very active uveitis, he had contralateral patching and atropine drops. By a couple of years later, the eyes were quiet, and his vision was starting to normalize, and the amblyopia was getting resolved. At that point, he was stable for quite a few years, and he wanted to consider, or his parents wanted to stop the adalimumab, at which point the team had suggested recruitment to the Adjust trial, which wanted to look at what is the likelihood of people having reactivation following adalimumab termination. But he declined it and stopped adalimumab anyway, and then presented 3 months later with bilateral AC inflammation +2, and adalimumab was restarted. Again, another graph for the Adjust study, which we've talked about already, which shows that stopping adalimumab essentially incurs a high rate of relapse. Yet another low timeline. We're now on to 2013. He's got no inflammation and really good vision in both eyes, 6 out of 6. Between 2013 and 2015, he had a few episodes of anterior uveitis, which were managed with topical corticosteroids. His adalimumab was increased to 40 milligrams fortnightly. The methotrexate was increased to 15 milligrams. He had a trial of adalimumab in 2017, and then presented a little bit later with, again, bilateral inflammation. At this point, there was a discussion had with the family about what they would prefer. The obvious option may have been to restart the adalimumab, but they wanted to stay off it. And so they opted to increase the methotrexate to 20 milligrams at the time. A few years down the line, 2020 now, he was persistent inflammation. And so he was then recruited for the baricitinib trial, which has GHW or Juve base, depending on the name that you go by. And yet another little slide about this trial, which showed that baricitinib has a use in treatment-resistant uveitis and JIA. So we're going on to 2020, reaching present time. He had persistent inflammation with the baricitinib on board. So this is not that long after he was started, but as per trial protocol, it felt that this was poor response to the baricitinib. So he was taken off the baricitinib and restarted on adalimumab. A few months down the line from there, the methotrexate was switched to mycophenolate, with the adalimumab continuing. And 5 years down the line, he had paradoxical psoriasis, which was thought to be secondary to the ADA, and that was stopped. He had an IV corticosteroid pulse and has been switched to tocilizumab. Important to know that his vision is still 6/6. And since we're talking about tocilizumab, I can't not include a few words about the aptitude trial, which was a single-arm phase 2 trial with a low number of patients, where the primary endpoint of reducing inflammation was not met and therefore didn't justify its phase 3 trial, but did show that in patients that have tried quite a number of medication, tocilizumab may play a role. This is Optus and OCT imaging of his eyes at present, essentially showing no optic disc pallor, no fluid. You know what a normal scan looks like. Any questions? I might just hand over to Ram now to take the question.
No, thank you very much, panels. What I'll do is probably quickly show some of the study results which have been rehashed. Let me share my screen and then let me know if you can see the slides. Is that okay, Panosh? Can you see them yet?
Not yet.
Not yet.
Thank you, Panayoti. Great presentation.
Thank you. That's very kind.
I suspect now you can.
Yes.
Okay. Great. I'll just show you some of the trials, but I'll run through them because most of them have been mentioned, and I will focus on the ones which haven't been mentioned. These are my disclosures. So this has been talked about, and just to mention, at that time, our key goal was to include JIA-associated uveitis because the regulatory bodies like FDA and EMA didn't recognize that chronic anterior uveitis without arthritis is the same disease, which we all now recognize as. People have shown that not only did we show it was incredibly efficacious, but as was pointed out by Megan, we were able to reduce the drops significantly to less than 2 drops in those on adalimumab. And of course, the holy grail in uveitis is no cell, no drop. And that is also much more possible in the patients who went on adalimumab. And this has been touched on. But perhaps the trial which hasn't been focused in all these talks is tocilizumab. And just to give you a bit of understanding of what we did, so when adalimumab has become the standard of care in methotrexate refractory patients, it becomes very hard to do a head-to-head trial. So what we did in this is what we do in pediatric oncology in those children with cancers when we trial new treatments. So we took the children who have already failed methotrexate and an anti-TNF. So these are really refractory patients. And then we gave them subcutaneous tocilizumab because it was increasingly becoming clear that many children don't want to come into the hospital for intravenous infusions. And in children with arthritis, we had already shown that subcutaneous tocilizumab is as effective as intravenous tocilizumab. So this was an open label trial, but we used a technique which is called the Simon design or a 2-stage design. What we do is the first 10 children will get open label access to tocilizumab, and we have a pre-specified endpoint of at least 2 or 3 successes for us to then move to a full complement of 21 patients. What happened in the trial was we were meant to get 22 patients, but we only got 21. One child dropped out for a host of logistical reasons. And we showed 7 of these 21 patients had dramatic response. And you have to look at the fact that these patients have already failed methotrexate and 1 anti-TNF. So these are reasonably refractory patients. And in these 7 patients, as most of you can appreciate, you can see 2+ becoming 0.5 at 12 weeks, 3+, 4+. So you have moderate to severe refractory uveitis, not responding to an anti-TNF and methotrexate, in a third responding to IL-6. So IL-6, which is a pluripotent cytokine, is effective in a third of the patients with refractory to anti-TNF methotrexate uveitis. But it doesn't work in another 60%. Probably another 20% get 1-step improvement, which is one of the problems with sun, because when you recruit 1+ patients, it's very hard to achieve 0. If you recruit 3 or 4+, it's much easier to show the 2-step improvement. Of course, adjust has already been touched on, so I'm not going to focus on this. But what is clear for most of us is, when do we stop? There are 2 reasons why it seems we are struggling to stop adalimumab. One is probably we are missing the immunological window of opportunity. Maybe we are initiating biologics too late, that they seem to need the drug for longer periods of time. Or immunologically, uveitis is a much more pro-inflammatory state compared to arthritis, and they will need treatment for long periods of time. The key variables to mention are, even though they are just inclusion criteria was you must have only inactive uveitis for 1 year, most of the patients who entered the study actually had inactive uveitis for 2 full years. So it seems even 2 full years of inactive disease is not enough to stop the drug. And I think it might be a combination of both reasons I mentioned. One, that there is an immunological window of opportunity. 2, uveitis does need longer-term treatment compared to arthritis. And of course, in our world, certainly the 2020s and this decade is the decade of JAK inhibitors. These, again, are upstream molecules. They have a host of effects. I'm showing you in this picture how they can have effects on hematopoiesis. They can have effects on Th17 differentiation, which is why they're used in inflammatory bowel disease, where the IL-12/23 axis is important. They work on alopecia. They work on atopic dermatitis, hidradenitis suppurativa. So they're quite pleiotropic in their actions on multiple cytokines. This data isn't published yet. It's in press, but we have submitted the abstract at a couple of international meetings. So I can show you, again, the challenge is adalimumab in methotrexate refractory patients is so efficacious. The trial landscape is becoming very difficult. How do you recruit in a head-to-head trial adalimumab naive patients to another drug? So our design was to take 20 patients who are refractory to methotrexate and are refractory to adalimumab and give them open-label baricitinib. But we also wanted some reference arm of comparative efficacy. So we wanted to recruit another 20 patients who will be randomly allocated to either adalimumab or baricitinib. But after 3 full years trying to recruit in 5 countries, we only managed to get 10 patients, because most parents, when they hear about this trial, they say, I will have the adalimumab, I don't want to go on the trial. But for those who are refractory to adalimumab, because there is no other licensed approved medication, it was quite easy to recruit them to baricitinib. And the primary endpoint was, again, a 2-step decrease in SUN. And of course, we used Bayesian analysis, which I won't go because of the time restriction. So this is the patient disposition. So we had a total of 19 patients who were both adalimumab and methotrexate refractory, as opposed to 5 patients in the adalimumab arm who were only methotrexate refractory and had not been exposed to anything else. What do we find? Again, this 30% response. About a third of the patients who are refractory to adalimumab do respond to baricitinib. But if you look at the bio-naive patients, adalimumab is far more effective than a JAK inhibitor. So the outcome of this study, or the take-home message, is the first choice agent after methotrexate still remains adalimumab. But for adalimumab refractory patients, tocilizumab or baricitinib, or depending on which part of the world you are in, tofacitinib is off-label and cheaper, are effective options, really. Where is the future going? We've just completed the first phase of our in-house investigator-initiated trial, looking at IL-17 inhibition in the form of secukinumab. And again, we're using the stop-go design, where we are taking the first 10 patients who are TNF refractory and giving them high-dose secukinumab, the same dose as psoriasis, rather than the dose for psoriatic arthritis. And if that shows a success, we'll do a 1:1 randomization to adalimumab versus secukinumab. And of course, all of us as uveitis specialists will have some patients who are refractory to multitude of agents. And for these patients, we are going to running a trial across 3 countries looking at intravitreal implant of Iluvien, which many of you may be using in your adult patients. I'll stop there and take any questions. Thank you very much.
Thank you very much, Dr. Ramanan. Very, very interesting presentation and discussion. I have a question. So in these patients refractory to adalimumab, should we measure drug and antibody levels? So do you think that one of the probable causes is the formation of anti-drug antibodies?
Absolutely. So we have primary lack of response to adalimumab, which usually you see in the first 3 to 6 months. And then you have patients who respond very well and around 18 months, 2 years, start having active disease. The first step in those is to measure drug levels and anti-drug antibodies. And if you see high levels of anti-drug antibodies, neutralizing anti-drug antibodies, and low levels of drug, then if they are not on methotrexate, because most of them stop methotrexate due to intolerance, you can consider mycophenolate or restart methotrexate. If your local healthcare system allows you to use weekly adalimumab, that is an option as well. In UK, we are not allowed to do weekly adalimumab. But if you have normal drug levels and no anti-neutralizing antibodies, then you should consider switching to a different biologic.
Okay, thank you.
I have a question for Ramanan.
Sure.
What do you think about adalimumab as monotherapy and first line before methotrexate? I mean, do you think there is a group of patients that we can treat with adalimumab alone? Measuring maybe antibody against the drug, and what do you think about that?
No, it's absolutely yes. We have published on this. We've compared adalimumab monotherapy versus patients who went on adalimumab plus methotrexate. It is effective. One of the problems, at least in the West, is methotrexate intolerance is a huge problem. And I think our first speaker already highlighted, if you have cataract, posterior synechia, or raised intraocular pressure, or macular edema, at onset you go on adalimumab. I think the reason we haven't gone for adalimumab monotherapy has been logistical in terms of cost and the restrictions. But now that it's biosimilar, the cost of adalimumab is relatively cheap compared to the healthcare cost of multiple attendances. So I think there's a strong argument to be made for early use of adalimumab with or without methotrexate, depending on the patient considerations. I'll put the manuscript I mentioned in the chat.
Okay, thank you very much. Our real life data agrees with what you are saying, because in the real life setting, many pediatric rheumatologists prefer to give adalimumab as first line.
Yes.
Thank you.
One of the interesting questions that came up, and I asked Stéphane Thoreau to join us as a panelist over, is about, do you want to just ask the question, Stéphane?
Yes, I'm ready to go. Hello to everybody. I'm Stefan Thor. I'm coming from Munich. One of the things I always try to avoid in any kind of topical treatment, at least in children, is to avoid any eye drops containing phosphates. Because band keratopathy is basically calcium phosphate. And if you add more phosphate on a topical, of any kind of topical eye drops, there is a significant risk you may deteriorate band keratopathy. So in addition, especially with dexamethasone, which comes as a phosphate, the dexamethasone is a pretty poor anti-inflammatory drug, and we prefer the prednisolone acetate. So from my point of view, there are two reasons not to use the phosphate and the dexamethasone phosphate. That is one, band keratopathy, and the other issue is the less effective drug, where prednisolone is probably much more better. But there is, in the last years, there's come up a third aspect, and that is the use, the content of borate. The borate as a buffer system in these eye drops, and probably also as a preservative, is that the borate may cause, if you use it in children, may cause sterility when they grow up and cannot get children. So I try to, this is a concern that has come up in Germany over the last years, that borate containing eye drops should not be used in children. I'm not really sure whether this is a significant effect, because the amount of borate that comes with eye drops is very, very little, and it's probably not sufficient to cause sterility in children, either male or female. But this is a discussion we have here in Germany over the last years, and I wonder what is going on an international basis. Is that discussion anywhere going on in any countries? Alessandra is you're just nodding your head. Give me an idea, please.
I know, and it's a very interesting topic because we have some very, very common medications that we are using in these children with phosphates.
Yeah.
So
I know the phosphates. That's one aspect. Yeah. Fortunately, with the prednisolone, there's an acetate. So that should work much better. But I know many antibiotics contain phosphates. Yeah, the buffer system is phosphates. So not just the drug itself, but it's also the buffer system in the eye drops that contains phosphates. So one really has to look very carefully at the content in these bottles to avoid phosphates. And the other thing with the borate, I would really like to ask the community, what is their feeling about it? Okay. Sorry for that question.
I don't know.
But it's really something that bothers us sometimes, and we have to talk to the parents. Yeah.
I've been wondering if anyone has in their country sort of some registry where you could assess infertility, like what we did with Sight with mortality. This doesn't seem to be very widespread, but anyway, if you haven't, let me know. Yeah.
No, I'm not aware of any. And looking at the amounts of borate you would need to for children if they use in childhood, it's not really clear how long does it take, what amount of borate is used. It's almost impossible to find this kind of information. But now it's a big discussion here, and I'm a little confused because many eye drops do contain borates. In reality, there's only one specific brand in Germany that's available that's phosphate-free as a steroid and borate-free. And unfortunately, at present, it's not on the market due to all these restrictions we had since COVID and all these limitations. So we are really a little concerned. Okay, that's another discussion. I see.
Thanks.
Well, thank you.
Yeah. I've been practicing in Ethiopia for some years now, and we seem in Ethiopia to have a lot of cases like JIA, which has been mentioned in the talk, but I've sort of begun to think of it as like anarticular JIA, and do we really just view all of this as the spectrum of the same disease? I think we do, but I'm just curious what people think.
We do, John, and if I may go first on that, I think one of the reasons you see a wide prevalence of 8 to 35% uveitis incidence in JIA is for two reasons. In the recent last 2 decades, when you get uveitis, ophthalmologists increasingly are comfortable with starting methotrexate, which means some of those children who are destined to get arthritis don't. So they remain as idiopathic chronic anterior uveitis. And then the other reason for the reduction is early aggressive use of methotrexate by pediatric rheumatologists mean that some of the children with oligoarthritis who are destined to get mild uveitis don't anymore because of our early use of methotrexate. Both these mean we don't see the mild uveitis we used to see, but we are still seeing all the moderate and severe uveitis, which remains a persistent problem.
Yeah, I agree with that statement.
Recommendations of the sorry.
No, it's okay. It's okay. I was just saying we presented data for a paper that's out for review right now using a large database out of the United States, the Trinetics database, that showed that the incidence of JIA-associated uveitis has declined within the last 15 years. And our main point of discussion was that concurrently the use of immunosuppressants in that same group had gone up, and that was most likely the culprit, not a change in the amount of disease presence. It's just if it's showing up or not.
Brad Gonde,
we have been treating we used to call them JIA-like before the idiopathic chronic anterior uveitis, because they behaved in exactly the same way. The phenotype was very similar, chronic, bilateral, all the complications. We would go for methotrexate first, adalimumab, and now we have, backup. We are being backed up by the recommendations of the SHARE initiative, where this has been incorporated. It wasn't in the first SHARE initiative, but now we have it. And as exactly mentioned by Ramanan, that probably the earlier introduction of immunosuppressive medications and biologics do prevent the occurrence of clear-cut uveitis. Uveitis later on, or arthritis. Later on. As in the presented case, the patient has a mother who had arthritis, and still she didn't. We know her now for 2.5 years, and she never developed any symptom of arthritis.
And just to add, in all our recent trials, we've included children with both chronic anterior uveitis without arthritis, and the European Medicines Agency has published a position statement saying in all trials of pediatric uveitis, both JIA and chronic anterior uveitis without arthritis must be included because they're the same disease, which is very helpful when you approach funders who say, oh, the drug is licensed for this, but not for this. Then you can say, no, all of pediatric uveitis or all chronic anterior uveitis with or without arthritis is the same disease.
Good. There was another important question, and I'm sorry we're going a bit late, but those who have to leave can drop off, as to what is suggested for a perioperative steroid regimen for cataract surgery or for other surgeries.
I am very reluctant to use injections, like ocular injections. I don't do this in children. We know that these children are at a higher risk of developing secondary glaucoma, as we have seen in the different publications. And this is the last thing I want to do, to expose them to steroids. Of course, we will need to use topical steroids post-operatively, but I would not like to give them an injection. If I need to optimally control them, I would definitely add to the regimen that they are using of methotrexate, adalimumab, I would use the systemic corticosteroids.
I put our response, we give a dose of IV methylprednisolone on the table pre-op, and then a short course of oral steroids.
Yeah, I like systemic because it's more flexible. Yeah. And it's not going to make them fail to grow to just give it for a few weeks or less. Good. There was another question about if with IL-6 inhibitors, it's been noted that they have a lot of effects on macular edema. And are there any, how does that play out in terms of your decision about what to do in these patients?
I did put a response, John. There's very good data to show that when you have blood-retinal barrier breakdown, I didn't show those slides, and that the IL-6 is the main culprit in macular edema. And in fact, aqueous humor levels of IL-6 mirror macular thickness. So if you don't have any restriction and you have a child with macular edema, tocilizumab is the agent of choice. But because of the licensing restrictions in a lot of settings, at least in the UK, we still can't access, so we use adalimumab. It's a pretty good drug. And of course, you shouldn't see the cytokine milieu as something in isolation. Blocking TNF will also block IL-6, and blocking IL-6 will also block TNF. There's a lot of interlinkage. And of course, one of the mechanisms by which JAKs work, JAK inhibitors, is by blocking IL-6. So they also block IL-6. But for a purist, the best drug if you have macular edema is IL-6 inhibition with tocilizumab.
I have one question regarding the stepwise approach of the biologics, like in patients who are refractory to the TNF alpha blockers, would you like go through a tocilizumab, or would you just go to the JAK inhibitors? Because we do have in our center also similar cases, where they are either primary failure or secondary failure with the TNF alpha blockers, and we do use tocilizumab in the meantime. But I have seen also greater results with the JAK inhibitors. So now with all the studies that you are conducting and running at the moment, are you going through the tocilizumab, or are you like bypassing it and going straight to the JAK inhibitors in these patients?
It depends on the access and the patient issues. If they are uncomfortable or needle phobic, then the JAK inhibitors are a very good option, because baricitinib is once a day, tofacitinib is twice a day, tablets comes in syrups as well. If there are any compliance concerns where we'd like to know exactly what we are giving is what they're taking, then we go for tocilizumab. But I think both options are very good options for those who fail adalimumab.
Is there any role for the anti-CD20 medications, like in this group of patients? Where is it right now?
Yeah, I think there was one Russian study which suggested they may work, but which was a small case series. Otherwise, the focus has always been on T-cell therapies and other. So my personal view is they are not going to be efficacious, but I haven't got evidence to say yes or no, and I don't know of anyone doing it. There's a group associated with us which is looking at the role of B cells in experimental autoimmune uveitis mouse models and so on. And that is basically, the question is about rituximab, which is, because it's biosimilar, is also quite cheap now, and you can just give it 2 doses 14 days apart.
I mean, when we read the histopathological studies about the infiltration of the iris and the ciliary body by plasma cells and B cells, so we think that it's logic to be using the anti-CD20 therapy. So I don't see a role of this medication in such patients.
Yeah, it's an interesting question. I think because in JIA itself is not a rheumatoid factor positive disease, so the rest of JIA, we don't use rituximab. Rituximab's role is only in the seropositive patients, which are essentially the young or the adolescent patients. But we need more mechanistic data on B cell involvement, and then some trials.
Okay, thank you. Thank you so much. It was a great session. And if John or anyone else have some more questions, or if not, we will close. And this one. Many thanks to all our panelists and attendees. And please remember to send in your presentation so we can begin writing the IUSD book chapter, please.
And our next session, is it April 12th, Alejandra?
Yes.
Yeah. So watch for announcements about our Grand Rounds 14.
Yes.
Good.
So we'll be sending the announcement. Thank you so much. It was a great pleasure to have you here. Fantastic panelists, fantastic presenters.
Yes, thank you so much.
Thank you so much.
Great. All right. Take care.
Thank you. Bye-bye.